Behind me, the Nordic Conference of Mental Health is taking place for the 20th time. Every year, around 1,000 therapists head for the small Norwegian town of Stavanger for 3 days of research, theory, lived experience and cultural expressions, all from the field of mental health. This year, the theme of the conference is Bodies of Experience, and we'll be exploring the role of the body in mental health. Alongside Pat Ogden, Alan Abbas, Steve Porges, Josie Geller and Susie Orbach, a highlight of the conference is going to be the discussion between Peter Fonagy and Bruce Wampold that you're about to see. In this discussion, we asked them what the future of psychotherapy holds, as well as how our current research on psychotherapy can inform future policy in mental health. So welcome.
I'd start off by welcoming Peter and Bruce. We're very happy to have you here on this debate on psychotherapy. And if you look at the books on the screen here, Peter Fonagy and colleagues have been writing the series on what works for whom, one on adults and one on children and adolescents, which is focusing on the evidence base for various treatments for various disorders. As well as Bruce Wampold and Zach Email have been writing the Great Psychotherapy Debate, which is based on an extensive review of the medical model versus the contextual model. And this is a topic that has been debated in our field for a long, long time, and it still continues to create a heated debate at some times. We saw some slides earlier, Peter, that you showed. But we are very happy to have you both here and learn more about your thoughts on some important issues that we'll be discussing. This conference has also looked at the issue before. In 2014, we actually handed out placebo medication, which didn't contain anything. It was sugar pills, of course. But we handed it out to the participants in the conference, and we also handed it out to the public in Stavanger to bring attention to the status of evidence-based treatments and also the placebo effect. Today, however, we're discussing 4 themes related to the current state of psychotherapy research and where we may head in the future. This is also the first time that Peter and Bruce meet up for a debate, so we're very looking forward to your thoughts on 4 important issues. And to start off, the first issue that we will be discussing is whether some psychological treatments are more effective than others. And Peter, can you start?
Thank you. Evidently they are, empirically they are, so it's not a long conversation. Some psychotherapies do not work, some work. There's no question about there being differences, but you can organize the ones that work in terms of certain parameters that we are particularly fond of, like who trained you in what, and what are your beliefs about the world, what are your beliefs about the mechanisms of the disorder, what are your beliefs about the mechanisms of action of psychotherapy. That doesn't predict very much. That doesn't mean that there isn't a difference between the extent to which psychotherapies work. It just means we're looking at the wrong question. So I think, is it a major distraction for us to be working in terms of what are probably outmoded constructs in relation to the effectiveness therapy? The answer is yes, but that's not the question that you asked. So I'm answering a different question. Is there an importance of figuring out our responsibility to our patients, what works and for whom? The answer to that is an absolute and unequivocal yes. And I would consider any attempt to hinder that process to be both unethical and unacceptable intellectually. So both in terms of values and in terms of the pragmatics of what governs the way that we work. How best to do it? Well, let's have a debate about it.
So you're saying that there are differences between the psychological treatments, and you're also bringing attention to ethics. You know, what's the ethical thing to do if you have an evidence-based for disorders in terms of what you provide? Is that right?
What I'm saying is, and I'll say it again, is that it is unacceptable for us to offer a therapy, any therapy, that we do not know works. What defines that category, okay, is a different matter. And I'm not saying that we've got the right definition. So when we say CBT works and psychodynamic psychotherapy doesn't, that may be entirely the wrong question and the wrong way. If we say that X works for Y disorder, X treatment works for Y disorder, that may be the wrong way of asking the question, both because of how we define the disorder and how we define the treatment. But I'm very emphatically saying not asking the question is unethical, but we have to be sophisticated in the way that we ask it, and I hope that we will, in the course of this debate, we will edify ourselves and edify those who are forced to listen to us in terms of asking the question in a more sophisticated way.
Well, the question we're debating is a very closed question, but I'll move over to Bruce. And the quick answer, Bruce, to this question: are some psychological treatments more effective than others?
Well, this may surprise the audience. Absolutely, yes. Some are more effective than others. But I'm not going to tell you exactly what the difference is for a minute, okay? So I've been attending conferences for 40 years about psychotherapies. I've listened to brilliant talks about new therapies and how they get to the heart of the problem of various types of patients. So we all know there was a day when psychoanalysis was the only game in town. They had an explanation for why people were neurotic and a way to fix it. Then came Albert Ellis and rational emotive therapy. Whatever happened to that? Cognitive therapy. Aaron Beck said, depression is caused by maladaptive cognitions and inappropriate attributions about the world. Then came prolonged exposure. We need exposure for every anxiety disorder. But then John Markowitz just showed that interpersonal therapy without any exposure seemed to work for PTSD. We have ACT, acceptance and commitment therapy, mindfulness-based CBT. I've written a few down here. I don't want to forget any of them. Panic control therapy, cognitive processing therapy. We have to include writing about your trauma. Oh, I don't want to forget Leslie Greenberg and emotion-focused therapy. How is it we keep developing new therapies? Okay. And the outcomes we get with patients really have not improved over time. This is disturbing to me. So, Peter, I was glad at the end of your talk you actually mentioned therapist, because what really makes a difference is the therapist. There are some really good cognitive behavioral therapists who do a great job. And when I say a great job, I'm not talking about they look good if you observe them. I mean they actually achieve good outcomes with their patients. But there are some very poor cognitive behavior therapists. Same with dynamic therapists, emotion-focused therapists. The key to success, and you got to the epistemic trust, is that some therapists have the skills to be able to help patients regardless of the treatment. The continued focus on treatment really puts the spotlight in the wrong place, okay? It's us, therapists, who make therapy work, and we need to put emphasis there. Okay, now back to the provocative part. Some therapies are better than others. Clinical trials over and over again, if you compare to treatments given by people who have allegiance to them and who have cogent rationale and ways for patients to work on the problems that bother them are just about exactly equally effective. If there's a difference, it's so small not to have a practical significance. What doesn't work as well in trials, although it works better than no treatment at all, is just sitting with a patient and being empathic, understanding. Okay? Treatments without structure, okay, without some way for the patient to work hard to overcome their difficulties, don't work as well as focused treatments. And CBT has really taught this. So in the eating disorder area, the trial that Stig Poulsen and colleagues did, where they compared CBT to psychodynamic or psychoanalytic therapy, the psychoanalytic therapy didn't do as well because the patients were allowed to come in and talk about anything they wanted. It was their choice. Well, talking about an eating disorder and the difficulty is difficult. So they avoided it, and so did the therapist. So they never worked on what the focal problem was. So unstructured treatments, therapists that just sit there and go, how was your day today or your week, don't get the same outcomes that people that are doing mentalization or CBT or behavioral therapy for eating disorders.
So it sounds like, at least if we look at this as a close question, you agree that they're not, that there are some psychological treatments that are more effective than others. But now we're into what works in therapy, and that's another discussion. What's your thoughts on this, Peter?
Let me take on from where Bruce left off, because I think we actually agree, although it's very boring when people create a debate and the two debaters agree. It's terrible.
I try to be a little provocative.
I will try. It's hard, So the way I would look at it, the very problem that Bruce said, that he kind of juxtaposes structured versus unstructured. I agree, but I don't agree that it's to do with the structure. I think that what happens in therapy across the 1,246 different kinds of psychotherapies that there are, is that if you have a decent scientifically or empirically based model of the client, and you are actually able to say something to the client that they find helpful, that they feel recognized by, irrespective really of the theoretical formulation that you use, actually the person increases their sense of epistemic trust towards that individual, regardless of the model of therapy. As epistemic trust increases, there is an increase also in the person of the therapist. And if the therapist is of the kind who is able to understand and treat as agentive the individual that they talk with, gradually epistemic hypervigilance, the exclusion of that person from the social environment that they are in, decreases. They become also better able to understand people and better able to mentalize. As a consequence, and this is the bit that I think some people in this room may find a little bit disturbing, and I don't know whether I'm going to be provocative or not, or sufficiently provocative. As a consequence, what happens is that the individual's attitude in the way they relate to their social context changes. So the benefit of therapy is not uniquely, or perhaps not even importantly, in the consulting room, but it's in the social network that that individual is in. The benefit is in the improvement of social relationship, particularly in the case of enduring long-term difficulties that we are mostly working with in psychotherapy. It is in the context of those individuals, we improve their capacity to learn from their social context, to change their expectations about that context, which in turn then help them adapt better. But it can start, the initiation of this is indeed specific evidence-based skills that they have acquired, the therapists have acquired in their training, that help them provide a coherent and clear enough presentation of the individual that they are in, so that their communication with that individual enhances epistemic trust, enhances the sense that I have something to learn from another individual. If you achieve that, you achieve, I think, an initiation of a process that has two forms. One, you become an interesting person, and two, the other messages that you have for that individual in relation to their social world will be better listened to.
Well, I agreed with everything up to the point where you said it has to be an evidence-based treatment, otherwise somehow this patient is not going to
I didn't
benefit
say that.
from
I didn't say. I said it has to be an evidence-based understanding of that person.
And what does it mean to have an evidence-based understanding? I would contend that every understanding we have of a disorder is wrong. We will find out in 10 or 15 or 20 years, every explanation you have will be supplanted by a new one. It's not necessarily going to be a true one. What's really important, and if you come to my presentation after lunch, I'm going to talk about this, is that the patient accepts the explanation, okay, whether it's evidence-based or not, and that it leads to the patient to do something to overcome their difficulties. And I agree absolutely with Peter. It's usually around the social world. And there's a reason for that, because we evolved as social animals. You know, people come to treatment very much because of their disrupted social world than they do for the symptoms. An OCD patient, well, they wash their hands a lot, that's distressing, but they don't have a romantic partner, they're not in an intimate relationship, they don't have work. Those are the things that bother people when they come. So in that way, we agree. I think we disagree about what the nature of the explanation we give to the patient is.
What's your thoughts on that, Peter?
I think if everything goes, nothing goes anywhere. The criteria, to me, are that something has to be consistently science-informed. It has to be organized around the client's intentions. It has to be culturally sensitive. And it has to consistently monitor the effectiveness of the interventions through fairly reliable or relatively reliable indicators of functioning. It has to be contextualized by the events and conditions that imply the treatment.
That's a long list.
Those are the criteria.
I would take one criteria and make it paramount over all the others. And that is, what we do in therapy actually helps patients. Okay, that's the bottom line for me.
Fine.
Therapists do a variety of different things, even giving the same treatment. As long as the patients are improving in an authentic way, I support that.
On that, I wouldn't disagree. But I would say that if you are trained in a particular modality, in a particular coherent frame, then you will be much better at communicating things to the patient that actually work. It can be a wide range of things.
I don't disagree. We should be trained in models.
Yeah, okay.
This actually ties well with the second question that we're talking about today. The second question is, how do we become better therapists? We have a lot of therapists here in the room. We'd like to hear your thoughts on how we can progress to become better therapists. And I'd like to start with you, Bruce.
Good. This is actually an area that really interests me, because The fact of the matter is, it's really difficult to become a better therapist. We go into a room by ourselves, we have confidential conversations. We really can't talk to many people about what happens. Maybe we have consultation or supervision. In the United States, once you're certified or licensed, it's no longer required to get any consultation or supervision. We don't get feedback about what we do. So we just published a study where we looked at therapist outcomes, the actual outcomes of the therapy over 18 years. And it's really distressing to find that on average, therapists get less effective as they gain experience. We can't tolerate that. We need to improve our skills. So how do you do that? I used to think, well, you need to know yourself better, you need to have more experience, see different kinds of patients. I've come to the point where we need to practice the skills that we know are employed by more effective therapists. So Tim Anderson's facilitative interpersonal skills, okay? He found out that effective therapists, the ones who have better outcomes, in challenging interpersonal situations, not just in any social situation, but in challenging situations with for instance, an interpersonally aggressive patient who's challenging. Verbal fluency, ability to be warm and accepting, even with the difficult, challenging patient. Empathy, okay. Recognition of affect of the patient, being able to express, which may be activation, but it also may be inhibition of our own affect, okay. The ability to form a good collaborative working relationship across a range of patients. The ability to explain what we're doing in therapy in a cogent way. Those are the skills that make effective therapists. We can't get better unless we actually practice them. So Pablo Casals, the famous cellist, was asked, why do you practice 5 hours a day in your 80s? And he responded, because I think I'm getting better. Okay? So we actually have to practice what we do outside of therapy. It isn't enough just to see 6 patients a day over a week and a month and a year and think we're going to get better. So practice.
Peter, your thoughts?
Couldn't agree more. Several levels at which I agree with what you say, but just to get more, it was a long list.
Yes.
Yours was a long list. I have one item in that list that is really critical. And that, to me, explains why we get worse. Your result, it doesn't surprise me at all. It's a lovely result. Why we get worse as we practice more. Because as we practice, we deepen our expectations. The way the human mind works is it develops prototypes. And we identify a person increasingly as just one of those. You know, we have the prototype, and this is just one of those that I've seen. We actually can make the mistake of losing what I think is the person-centered, critical person-centered aspect of what the process I was trying to describe. The person has to feel recognized as an agent. And if they are recognized as just one of those, with whatever the label is, that will miss something. And as we get better in terms of being able to recognize things, we also get worse at being recognized the individual. Can I just finish? And then okay, now come on, go on.
But Peter, I agree with you. But when we get up here and we talk about what is the problem with eating disorder patients, it's their mentalization. Or we talk about it's the culture. We're already putting this disorder into a category which works against the very thing you were talking about, in my opinion.
Okay. I don't want to go into giving my talking. Let me just answer the question. I'll come back to that later on in my answer to something else. But I want to come back to the practice issue. Because one thing that we introduced in the UK as part of the Improved Access to Psychological Therapies program that I was overseeing for children and young people, our program, was a compulsory part of training where people had to be videoed. They had to be videoed, and the supervision had to be of an interaction that was a videoed interaction between them and the patient. And as soon as, this is my experience as well, as soon as you see yourself practicing and see yourself doing, just like when we videoed mums and babies, as soon as you see, you notice things that you're not aware of, and you notice things that you're not. Let me just give one little example. One of the things that Anthony Bateman and I had identified in looking at videos of mentalization-based treatment, all in the same model, variable outcomes in terms of therapists. One of the things that occurs to a therapist when the patient goes into what we call pretend mode, and the therapist really doesn't understand what's going on. The therapist does this. They fold their arm like this, they tilt their head to the side slightly, and they say, like that. And we find, probably, this is not a scientific fact, but probably the vigorousness with which they nod their head corresponds to the negatively to their understanding. So the less they understand, the more you replace their understanding by vigorously nodding. Yeah. So we invented this device that you put a little transducer around the neck, and as soon as you start nodding, it beeps into your ear and tells you that you're not really following the patient. Now, in a sense, I'm making a joke, but in a sense, I'm saying something that's deadly serious here. That is, unless and until we put supervision, but that supervision that's based on actual clinical material, rather than one's fantasy about what occurred, which incorporates all the cognitive misattributions that I think we are both very aware of, that unless you actually do it on what had happened, it's probably not very useful. So you really want to watch yourself work and watch yourself work with another person.
Yeah. So I would just add, and practice alternatives too. So what can you do differently? How can you show empathy at that moment, that this is actually a time when the patient feels lost, him or herself? So we have to identify it in the supervision, those difficult moments, and then practice the skills that we know will make the treatment more effective. So just one step further, and I think you probably agree with that as well.
Yeah, absolutely.
Yeah.
So practice is something we agree on. Now, the third thing that we're going to discuss is looking at how do we build better services. And I'd like to start with you, Peter, because you mentioned the increased access to psychological therapies in England, which you've been heading the child and adolescent part of. Can you give us some of your thoughts in this process that you've been through and how we go on in the future?
Yeah, I mean, it's very difficult. You mustn't underestimate the difficulty that's involved in trying to implement something at scale. It's very easy for us to talk like this about what should be done, but as soon as you're faced with the need, in England we have about 10 million children between 5 and 18, of whom 1 million have a mental disorder, of whom currently about 180,000 get treatment of any kind. That the majority of kids, the vast majority, gets no treatment whatsoever, for various reasons that we don't need to go into, partly to do with resources, partly to do with stigmatization, partly with a whole range of things. We can go into it, but it's a major difficulty, a major challenge. So what can be put in place that improves access so that my ambition at the moment is to get just 70,000 more kids into treatment. That's the target. 70,000 sounds very little, but it's actually a major, when you're thinking how many more therapists that we'll need, it will need at least another 3,500 therapists that you will have to train in evidence-based methods and monitor, as we were both saying, the effectiveness of. So we tried to put in a program that had what we felt the key components of what makes for a powerful evidence-based intervention that evidence shows is effective. So it has a scientific basis, but actually that's probably not the most important part. The most important part is that it involves the participation of the child, young person, or family in the choice of treatment, in what it is that they want to have. And also the designing the goals for that treatment. So setting goals for the treatment, goals that they can be monitored throughout the treatment, whether they are attaining those goals or not. And I'm very proud to say that in our initial evaluation of the interventions that we had implemented, 80% of the kids and families rate what they received as moving towards the goals that they had set. Now that to me is critical. But also you have to set in place an implementation, a massive infrastructure. It's not enough to train your therapists in the techniques that they need to use and in the way they can adapt the technique to the particular individuals that they see and use the skills that are appropriate. You also have to train the supervisors so that they can supervise in the way that I think Bruce and I are agreeing with videos and give feedback in the way that I think we both agree is essential. But that's not enough either. You got to train the managers, the people who organize the service, in how the services should be delivered. Now, terrible things happen in the world out there. All this sounds easy, but in the meantime, there are reductions in investment in the services. People the senior people get removed from the service. There are massive challenges to any time that you're trying to bring things to scale. And to me, the answer, the one-word answer in this is you believe, you know what you're looking for, and you persist, and you use another science that we don't normally talk about, but I want to bring to the conversation here, implementation science. The science of how you can bring things to scale, and you use that research evidence to guide what you do. But to maintain that this is something that can be easily done or is straightforward is illusory.
I think that's a good point with implementation science, and what you've done in the UK with both the adult IAPT and child and adolescent one will give us a lot of insights into that. Now, if we have a thought experiment in terms of giving you guys $100 million in the Norwegian health system, would you go the way they've done in England with the IAPT type of organization, or how would you think about this, Bruce?
Well, there's a few things I agree with Peter on, that access to care is the biggest issue. So in epidemiological studies in the United States, 50% of the people who have a DSM disorder in a given year don't get any treatment at all. So we need to expand and the services, but also stigma is an issue. But in the United States, it's not as big an issue as who pays for the services. So let's expand services with the millions of crowns that we're going to put into this. You know, for the most part, and we've looked at data, and they've looked at it in the UK as well, therapists of a variety of different orientations or methods get very commendable outcomes. Okay? So let's all take a deep breath and say, on the whole, we're doing a damn good job in helping patients. What we find when we look at that data a little closer is that there is a bottom 10 or 15% of therapists whose outcomes need to improve. We could improve the quality of service by excluding those 15% or helping them improve. That would be, in a population level, result in a significant improvement in the recovery rate of the people we see. So rather than spending the money, though, rolling out, and this is criticism I have of what's happened in the UK, of training the therapist that you have to give this evidence-based treatment, and that's the emphasis of improving the quality of services, is a waste of money. Put the money on hiring more therapists and making sure that the outcomes they achieve meet some benchmarks. Okay. One last point, and you mentioned as well, Peter, but I'm going to emphasize it. There are quite significant agency differences. The climate in a mental health agency has an effect on patients, both directly because the patient calls the agency and gets either treated rudely or with respect. There's a climate for the therapist working there. Is their work valued, and is there an attempt to improve? So I work with an agency in Calgary, the Calgary Counseling Center, the biggest mental health agency in the province. And over time, their outcomes improve because they're doing exactly what Peter said. They're filming the therapy, they're giving supervision, they're working on the difficult cases. So let's look at the agency level, the therapist level, and spend the money in improvement and hiring additional therapists.
So it sounds to me that you agree on, this system is becoming more accessible, that we can use feedback systems, etc., and have more focus on training. And I think, this is a discussion that we could have used a few hours on, but minding that we have 5 minutes left, I want to give you guys 2 minutes each on your thoughts for the last question, which is, where do we go from here? The future of psychotherapy research. Where do you think the gaps are, and what's left to learn? Shall we start, Bruce?
Well, I've said this several times, and I'm going to say it again because I think it's so important. 10 years from now, I said 90, but I'm going to up it to 95% of what we know about therapy will be new. We don't know very much about what makes psychotherapy effective. If I had the money to fund the research grants for the future, I would quit funding comparisons between two treatments. We spend in the United States $100 million or more over a course of a few years comparing two treatments to find out that they both work equally well and better than no treatment at all. Let's study therapists. What makes an effective therapist? What do the therapists who get consistently better outcomes do? We're starting to answer this question, but there's more work to do there. It's a social influence model. The person of the therapist, us, are the critical feature in this. And so we need to study what we do that's effective. And that will change the way we train therapists. It'll change the way we improve. It'll change the way we do supervision. That's where I want to put the emphasis in the next 10 years.
And Peter?
I think that there are two aspects. We treat mental disorder, and there are two aspects of mental disorder. One is a very general aspect. As we are learning, there's one very general aspect, a general psychopathology. And we need to learn how to deal better with general psychopathology. And then there are specific diagnostic conditions. These, interestingly enough, these two aspects are orthogonal. They are actually not correlated with each other. The general aspect of psychopathology predicts how persistent a disorder is. I think we need to understand both mechanisms better, as Bruce says, but even before that, I think we need treatments that address separately the general aspects of psychopathology and the more symptom-specific aspects of psychopathology. That we can do now. That's research that we can undertake now. I think, secondly, psychotherapy research is too little too late. You never asked me what I was going to do with my $100 million. But what I would put the $100 million, I'm a child specialist, so I would say this. Where I put the $100 million is in prevention. That is, we need to understand better the disease mechanisms to prevent and make therapies more specific to the particular mechanisms that go wrong for individuals who acquire psychopathology. Our therapies are far too broad. The reason that all therapists are effective to some degree is because they address this general psychopathology rather than the specific symptom-oriented psychopathology for the most part. I would, if I had the $100 million, more research in understanding that process, but actually earlier on in this kind of stopping people from falling into the river rather than spending all the money on pulling them out.
Jon, can we each have 50 million?
We can discuss that over lunch. But I'd like to thank you both for, I like to stop with the idea on prevention. I think that's a good thing to end this with. But if people are more interested, these are good books to consult. And thank you both again for doing this debate.
Thank you.
Have a good lunch.
Thank you very much.